Hi, I'm Tim Wiedrich, Section Chief for the Health Resources and Response Section with the North Dakota Department of Health. And this is the Wednesday operational briefing for hospitals. If I could just remind you to make sure that your telephones and your video conference units are on mute if you're not actually speaking, that would be very helpful. Well, let's go ahead and check in with Tim Blazel with the North Dakota Hospital Association and see if Tim has any opening comments.
Thanks, Tim. Appreciate you hosting the call. I guess the only comment that I would like to make, I guess we're all aware of it, is that we do appreciate the mask mandate that came out last Friday from the governor. So again, we believe that's going to hopefully help our healthcare systems and the hospitalizations and stop the community spread. So we've actually put together a op-ed letter that we have sent all the newspapers here in the state, so we hope that all gets published. So again, just want to make a comment that we appreciate the executive order from the governor last Friday night.
Thanks, Tim. Well, we have a segment that we do on many of the programs called the Surge Resource, and this is intended to be information about things that are in the state medical cache that could be of use to the hospitals and other medical facilities as well. And so for today, we're going to walk through a description of the mobile medical unit. And to do that is Angie Strand, who's the interim director of the hospital preparedness program. Angie?
Good afternoon. Can you guys hear me okay?
I can hear you just fine.
Excellent. Okay, so good afternoon. I'm Angie Strand, as Tim mentioned. I'm going to be going over the North Dakota Department of Health Mobile Medical Unit, or what you might hear called the MMU. Next slide, please. The MMU is basically a medical emergency room on wheels. It does have a very large footprint, approximately 100 feet by 50 feet, to fully extend the 3 pop-outs and to accommodate the ramp and stair setup. And this is a picture of the full rig setup. Next slide. It's used to respond to emergencies and other events when hospital, emergency, and or patient rooms are not available. It's a semi-trailer that's been remodeled into an emergency room with 8 fully functional emergency stations and can surge to accommodate up to 16 patients at a time. Next slide. And this is another picture of the interior setup. And I believe the next slide is the exterior. Yep, so those have the pop-outs deployed as well as the ramp and stair setup, and that's out at DAPL when it was out there. Next slide. So the MMU is transported by a semi-tractor. The driver must possess a commercial driver's license, and the semi-tractor includes a sleeping area for the driver. Next slide. The MMU carries its own generator to produce power during outages or where power is otherwise unavailable. Next slide. Another truck that contains all supplies needed for MMU functions will be deployed with it. It serves as an emergency response asset for North Dakota and the region, but North Dakota emergencies will have priority. Next slide. The MMU arrived in North Dakota in mid-May of 2015 and was obtained from the Minnesota Department of Health. The North Dakota Department of Health currently owns the MMU, and it is part of the state medical cache. It's housed and maintained just like any other mobile asset managed by the Department of Health. Next slide. So some examples of situations where the MMU would be used for, but not limited to, are power outages that is not alleviated by emergency generators, a flooding or tornado or other natural disasters has closed or damaged a hospital, a disaster has caused injuries in a place or in such a manner that it's difficult to get victims to hospitals, such as an explosion, in a rural community. Patients are arriving at a hospital in greater numbers than the hospital has emergency department space for. And also the MMU can be used for large public events to provide backup or primary care in the event of multiple medical needs during a shortage of hospital assets. Next slide. So for maintenance and staffing of the MMU, staffing, storage, transportation, supervision, setup and teardown is provided by the Department of Health. When the MMU is being utilized by an existing medical facility, physicians, nurses, and other medical providers of that facility will provide the staff. When the MMU is being operated by the Department of Health, staff from the Medical Reserve Corps, as well as other North Dakota Department of Health staff will be assigned. Next slide. So some steps to take for the deployment of the MMU in emergencies, local public health, hospitals, emergency managers, and other officials can request the unit from the Department of Health. If the Department of Health becomes aware of an emergency that might be better managed by the MMU, the Department of Health will contact local officials to determine if the MMU should be deployed. These are merely suggested actions, but please don't hesitate to seek advice on MMU deployment and the needs by contacting the Department of Health Operations Center 24 hours a day, 7 days a week at 701-328-0707, or you can contact me directly in Unified Command Logistics at 204-1276. So this is all that I have. Here's my email and cell phone number again, and I'll be happy to answer any questions at the end of the meeting. Thank you.
All right, thank you, Angie. Let's go ahead and have some conversation now about the Binax Now rapid test, the distribution of it, and some of the processes that are being outlined for acquisition of the test. And so let me turn first of all to Nicole Brunell. Nicole?
Hi, Tim. I'm so sorry. Can you repeat that? I'm in the middle of driving and I didn't hear exactly what you said.
Sure. We're on to the Binax Now conversation. And I don't know if you or Seth are taking the lead, so whichever one should be initiating.
Okay. Well, I can talk about it a little bit first if you want, Seth, or you can do opening remarks.
Sure, Nicole. I can take the lead here since you're driving, and feel free to interject if I miss anything. So, good afternoon, everyone. Just wanted to have a little discussion today in relation to a potential antigen testing device that some of you might be familiar with already in the critical access hospital world, but something hopefully that can be of benefit to you as we look to have increased modalities for rapidly identifying COVID-19 in some of our rural settings. And so I have several key stakeholders on the call with me this afternoon to help review some of the questions and some of the processes that are surrounding these devices. I know that some of you are quite familiar with them based on things that you maybe have heard previously on calls and maybe in some of the news broadcasts that have displayed them across the nation. However, just wanted to have the opportunity today to present some information on how those can be utilized within your critical access hospital setting. Our hope is to have those available to you as a resource here in the very near future. Would like to talk about the potential resource that they allow you to have that rapid identification of COVID-19, and then answer any of those questions that might be underlying regarding potential barriers. And so as we kind of kick off the conversation here today, I think the first question that has come up by many individuals in regards to this antigen test is the concern regarding CLIA and CLIA waiver and what that looks like for critical access hospitals. And so I believe we have Bridget on the line with the Department of Health, Division of Health Facilities, who oversees CLIA. So I'll turn it over to Bridget to kind of start off by reviewing what is required for a critical access hospital who would want to perform this test with their CLIA. Bridget?
Thanks, Seth. As a critical access hospital, you are all familiar with CLIA, and I know you all have a CLIA certificate. The question that needs to be addressed by your organization is when you are bringing the Binax Now on to your into your critical access hospital, is if you want to include that testing under your current CLIA certificate, which is either typically a CLIA certificate of compliance or accreditation, depending on your organization, or if you have a separate CLIA certificate of waiver that you want to add it to, or if you want a new one. So I guess what we're wanting the critical access hospitals to do is to contact our office and let us know if you're adding the Binax Now testing, any COVID-19 testing to your test menu. We need to just make note of that in your CLIA, our CLIA system, so that we have record that you're doing the COVID-19 testing. The laboratory director, this is probably one of the most important parts. If you are adding it to your existing CLIA certificate, the laboratory director needs to approve that. So if you are planning to do that, that will be one of the first questions that Shelly or I ask you, is if it's been approved by your laboratory director. If you want to have a new certificate to keep this testing separate from your existing CLIA certificate of the main lab, just notify us as well, and we will work with you to get a new CLIA application. And I need to let you know which email we want this correspondence to come to. So give me just 1 second while I pull that information up. If you could send an email to CLIA, which is CLIALAB @nd.gov. So CLIALab@nd.gov. That is a CLIA specific email that will come directly to Shelly and I, so that we can make sure that we know the wishes of your organization. Again, we know you all have a CLIA certificate at the critical access hospital level. We just need to know if you are wanting to add the COVID-19 testing to your existing CLIA certificate, what that CLIA number is, and that the laboratory director has approved that. Or if you want to have a new certificate of waiver, we will work with you to get the CMS 116 application and fill that out.
Thank you, Bridget. Appreciate that overview of the CLIA process. The next thing I just wanted to review a little bit was just give a high-level summary, I guess, of the Binax Now for those of you who maybe are not familiar with it. And so I know several of the critical access hospitals have historically been using different types of antigen tests. And so some might be using different platforms such as the BD, Sophia Quidella, various platforms to go ahead and perform those rapid diagnostic tests in your critical access hospitals. The Binax Now is a COVID-19 AG card. And so there are a few different ways that this test can be utilized within your critical access hospital. The first that the Department of Health is allowing or advocating for is for any patients or healthcare workers who might be suspected of having a COVID-19 infection. And the recommendation with that is to go ahead and have that occur within the first 7 days of symptom onset. Another potential way that this test could be utilized within your setting is for ongoing surveillance testing of asymptomatic healthcare workers. And so we know that there's been a lot of questions from hospitals throughout the state in regards to testing their healthcare workers on a frequent basis. And so the Binax Now provides you with a potential modality in which you could test those healthcare workers on a consistent or recurrent basis. So maybe every 2 to 3 days, doing a Binax Now on your healthcare workers, your direct care staff, in order to see if you maybe have someone who's asymptomatically carrying the virus within your facility. And Brenda kind of has this nice sheet up on the screen, kind of what I'm reviewing with you right now. We'll get that over to Tim and hopefully can be sent out to the group here by Friday. We have just a few additions that we need to make. Also on this sheet, as you can see, it includes a link. And that is for anyone in your hospital, whether that's the lab director or anyone who's going to be performing the test, that they can click on that link and go online and review some very brief, concise, and comprehensive modules that really go through the process of utilizing the Binax Now test kit. And they're very, like I said, short in nature, probably 3 or 4 minutes each. So I would encourage anyone who's going to be performing the test to go ahead and review that link that was put out by the manufacturer in order to make sure that everyone's feeling confident and competent. Some other questions that we get in regards to this test and how it kind of works with maybe some follow-up or resulting that needs to ensue. So if this test is performed, a positive test result on the BioNXNow is considered to be a true infectious positive test, and that individual should be presumed to be contagious in nature. It can be considered diagnostic, and so if someone tests positive on the BioNXNow, they should immediately proceed to isolating, quarantining, and following the associated recommendations from public health and the Department of Health. With a negative result, it really matters on the type of individual that you're testing. And so a negative result on the BioNXNow does not rule out that an individual could possibly be infected with COVID-19. But it really, again, depends on whether or not you are testing a symptomatic individual or doing surveillance or sentinel testing on asymptomatic healthcare workers. And so just to clarify that, if you test someone who is symptomatic on the BioNXNow and the BioNXNow yields a negative result, you still need to obtain a PCR swab of that individual and send that off to the state lab for further diagnostic analysis. However, if you're doing routine, ongoing testing of asymptomatic individuals, such as in a critical access hospital, the healthcare workers, and testing them every 2 to 3 days, that would not require an associated PCR swab if it's being utilized for asymptomatic individuals on a consistent, ongoing basis. A little farther down, it just goes through some of the test site obligations that we've kind of outlined here today. I won't go through those in great detail today. But again, on this sheet that Brenda has up on the screen, we're going to have some contact information added to that and hopefully have that out to this group here in the next 24 hours. So kind of the summation of today's message is we'll have the contact information on this sheet for who you would want to get in touch with at the Department of Health if your critical access hospital was interested in ordering some of these BioNXNow devices. There is a quick checklist that the staff will go through with you to make sure that you have the appropriate CLIA waiver that Bridget just touched on, that the training has been completed, and that, obviously, critical access hospitals should have the appropriate PPE, staff that are fit tested, etc. But after that quick validation checklist is completed by a team member from the Testing and Strategy Division of the Department of Health, you can then put in your request for formally ordering the BioNXNow testing device through the HAN assets. And so the other part of this that really is key is the reporting piece, because obviously anytime we're performing a test that needs to be reported. And so for that, we also have on the line today Kirby Kruger. And so I'll turn it to Kirby, just a quick review how this would affect critical access hospitals and their need to go ahead and report out any tests that are performed via the BioNXNow. Kirby?
All right. Hey, thank you, Seth. Hopefully you can hear me. I really appreciate the opportunity to be able to speak to you today on this, and I really appreciate everything that you're doing out there on the front side of this pandemic response. And as Seth mentioned, the antigen testing that has emerged and has received FDA emergency use authorization. There are a number of different platforms out there. Seth was talking specifically about just one of the platforms, the Binax, which is sort of a card-based and can be used point of care. But there are other platforms out there, most of them involving at least a laboratory instrument and requiring some analysis on using a laboratory instrument. But regardless of what antigen testing you're using, COVID-19 is a reportable condition in North Dakota, and so it requires that laboratory results and physicians who are making diagnoses to report. So there are several options available, and I think the good news is that for a lot of the critical access hospitals, many of your laboratories are already have electronic lab reporting in place. And if that is the case, then these Binax tests, if they're being entered into your LIMS system, your laboratory information management system, that is already in place. And you would just need to follow up with us to be assured, and we can verify that the messages that you are sending on the antigen test results are being reported to us. And I'll give you some contact information a little later. And Seth, I was going to ask you if we can include our contact information on your sheet that you'll be sending out as well for reporting purposes. So there are other variety of ways. If your laboratory is not currently doing electronic lab reporting, but you have a lab in your facility and you have a LIMS system that might be able to generate a message, that would be the preferred method for us to try to work with you to see if we can get a message generated out of your LIMS system and into that we can receive into our disease surveillance system. So that would be the first option if you're not currently reporting through your lab. If that is not a possibility through the laboratory, or if that's going to take some time, there are some other solutions that we're working on. There is an online disease report card right now where you could go and you could submit test results electronically through the online system. And I will provide that website here in a little bit. The other option would be is that we have developed a spreadsheet and we can get that sent out to you and give you instructions on how you can submit a spreadsheet with a roster of your the people you've tested and their results through a secure file portal and a transport system. And so that is a possibility. The other part of, or another possibility would be we're working on developing a module in HC standard. And I understand that many of the critical access hospitals are familiar with HC standard. So when we get that module completed, that would be an option as well for reporting. We are working with, on Monday, we'll be meeting with a private firm that has the ability to accept test results and format them in a way that we can use them. I think it will have a good application for basic care and long-term care, but it might have a basic care and basic care and assisted living. But I think it might have an application for the critical access hospitals that don't have other options in front of them, or it may be a more attractive. I don't know enough about it right now to tell you just how good this is and what it will all involve, but we are pursuing other means. I think the idea is that we really want to have a method of reporting that is going to be the least cumbersome and least labor intensive on both of our ends, on your end and on our end. We can, the idea that if we have to do data entry that is already being done on your end because you're required to record the test results somewhere, if we can avoid that deduplication, that would be great. On the other hand, we don't want you to have to enter in that data twice on your end. If you're already entering into a system, is there a way that we can work with you to get that information out of that system? And that might include your electronic health records or your electronic medical records. If you can generate a message, with that, we would really try if we can make that work. So, in summary, I think there's a multitude of ways that you can report. If your laboratory is already doing electronic laboratory reporting, that's the way to go. If you have a laboratory that isn't doing it, but it's a possibility, I think that's our first choice, that we'd want to work with you on that, especially if they are entering those results into that LIMS system. Then there's the online report card. There's the spreadsheet in the secure file transport system. And then we'll continue to work on finalizing reporting through HC standard, and that might be an application that you could use as well. For the online report card, if you need to start reporting immediately and you don't have any other way to do it, if you're faxing or telephoning us, you can do the online report card. That can be found at ndhealth.gov/disease/report card. And report card is just one word. And the other thing that you can do is, if you're wanting to figure out how best to report, we have 3 people that can help, that are designated to help out with reporting. Mike Benz, Sherry Renton, and Ben Schramm. And if you call 701-328-2378 and just ask about how to report diseases, and ask for either Mike Sherry or Ben, they can certainly help you with that. But that's all I have. Hopefully we can help assist you to get reporting into place. We are interested in both positives and negatives, although we understand that until we get systems into place, the priority would obviously be getting those positives reported to us, but we are interested in both positives and negatives as well. And I think that's all I have, Seth. If anybody, I don't know if we're taking questions at the end, but I appreciate the time here.
Yeah, thank you, Kirby. I appreciate that contribution. So I think just to kind of wrap up our conversation here today, and then I'll certainly turn it over to Nicole Brunell and Brenda Fossler, who have been instrumental in kind of helping us with this, if they have anything to add. Really, just make sure at this point in time, you either determine what you want to do with your CLIA waiver, whether it's, as Bridget said, adding that to your existing CLIA waiver or applying for a new one. In addition, we'll be getting the document out to you here in the next day or so that hopefully gives you the high-level summary of important things to know, as well as the contact information for who you need to contact under the testing and strategy branch to go ahead and get that initial checklist completed so you can order Bionex now for your critical access hospital, as well as we'll be sure to add that contact information as Kirby requested for his group over with the reporting side in case there's any questions that ensue about how to report a test that is completed. If someone is really eager to get these tests going today, though, I do want to go ahead and share, and maybe Clint can help me by putting this information up on the screen, the contact person who will be with that testing and strategy branch, and that is going to be Shar Stroh. And so you can either email or call her. If you'd prefer to call, sometimes that's the quickest and easiest. Her direct number is 701-328-2697. Again, 701-328-2697. Or her email is cstroh, so CSTROH @nd.gov. So that would be your point of contact if you're needing to get that Bionex initial request made. I think the other high point I just want to share is really these tests are meant to be a benefit to our rural areas. And hopefully, like I said, the governor, I know if you've listened to any of his press conferences, is really hopeful that these will be utilized to help remove some of our asymptomatic spread that we're seeing. When Dr. Birx from the White House COVID-19 task force did her visit to North Dakota, that was one of the main opportunities she shared with us, was that she felt we had the ability to continue to identify and remove more asymptomatic spread in the community. So hopefully these devices will allow us to be able to do that with our healthcare workforce, and also be able to provide that just-in-time result where we're not having to wait for several days for a result when we maybe have someone who's displaying symptoms, and we can get a result in as quick as 15 minutes. So with that, I'll turn it over to either Nicole or Brenda if they have anything else to add.
Hi, yes, and I'm not driving, but I'm riding in the car. Just want to make that clear that I'm not on the phone at the same time. But I did want to address some of the Bionex concerns that I have been hearing, and just the quality of the test. So when these first come out, we did do a lot of testing performance comparison to the current PCR gold standard test. And I wanted to kind of share some of the information that we have obtained on that project. So with the symptomatic patients, when the Bionex is positive, we received a positive PCR test on all of those. And that, I should say, is symptomatic and asymptomatic that were positive on the Bionex also had a positive PCR test. So that is why the Department of Health and Kirby's crew is right on board with considering that as a positive test for COVID-19. So you would not have to follow up with a PCR test. We are confident that the positive Bionex is also a positive PCR test. Now, if it's a symptomatic patient and that Bionex now comes back negative, you do need to follow up with a PCR test right away. For the asymptomatic patients, if you're seeing them, it's not a surveillance, just they're in the office, want to get tested, you can do a Bionex now. If that virus load is high enough, the Bionex now will pick it up. If it comes back negative, then you would want to proceed with a follow-up PCR test. So with the different platforms or different ways of utilizing this test that we had talked about, you can use it either on your symptomatic, asymptomatic patients, but follow up with a PCR if it's negative. If you're utilizing it for surveillance for your healthcare workers, then you would want to be utilizing this test multiple times a week, because a result on Monday might not be the same result the next day or in 2 days down the line. We don't want it to replace PCR testing, but it's definitely a huge benefit to know if your patient, your residents, or your staff member is positive right then and there, and not having to wait those 48 hours to get your results back. So this test is definitely something that is going to be beneficial, especially in our critical access hospitals in our rural areas, to be able to identify those positives as soon as possible. So if anybody has any questions on that, I'm here to answer all of that.
Nicole, this is Carla at St. Andrews in Botno.
Hi, Carla.
Just some questions. Hi, how are you?
Doing good.
Good. Just some questions. I know that the providers will have. You talked about the comparisons that you did. What number, like what's the total that you tested or ran that comparison on? I know in the statistics that you have related to that, is that all going to be in your information that comes out on Friday on the Binax information?
I'll have to ask with my state health officer if that's something that I can share in a written format. So that was one of my concerns too when Binax first came out. The testing study that they did initially that they sent in for the EUA was only on 102 patients, and it was strictly symptomatic patients that developed an onset of symptoms within 7 days. So I thought that was a really low number. So we've done, I think, close to, I don't have the figure in my head, an exact number, but I think it's close to 700 PCR tests in comparison to the Binax Now test. And we identified when they were positive Binax, they were positive PCR, was able to validate that. So they do not have the ability, though, to pick up some of the lower virus load asymptomatic patients. So I'll give an example. We did some students, and out of 141 of them, we were able to identify 12 right away that were positive, that we were able to isolate. And then we followed up with the PCR testing, and there were 12 that were not picked up by the Binax, but were picked up by the PCR. So it's a bilateral nares. So that virus load has to be there, and it has to be high enough for the Binax to pick up. Otherwise, our amazing machines that we have at the lab are able to break that down and detect it at lower levels. Did that answer your question? I'm so sorry, Carla.
No, it did. I know because Dr. Scholden asked that, I believe, on Friday's meeting, this same meeting. And so this is good information to have to take back. But I think what we were hearing was like a 50% false negative on those. So we were just wondering. Yep. Thank you.
Yep. And that's why it's incredibly important that we communicate that really well out to our patients. So just because that Binax says it's negative, that does not mean that you couldn't possibly be positive. Especially when our close contacts are coming in, we don't want them to think, oh, well, my Binax was negative, I can go out and do whatever I want. So that communication definitely has to be clear when utilizing the Binax, and then making sure that we're following up with that PCR testing on those close contact symptomatics. So surveillance portion of it, you wouldn't have to follow up because you're doing it multiple times a week, but to have that consistency.
Thank you.
Questions and answers in just a little bit, but we have a little bit more material to go through before we get there. And so let me check in. Brenda, did you have any additional information that you wanted to bring as well? Not hearing any. Seth, Nicole, is anything else that we need to close out this topic?
No, I think we were able to hit everything. Thank you so much for having us on, and please reach out to me if you have any questions. Thank you all.
Yep, I agree, Tim. We'll be available at the end for any questions that ensue.
Great.
Thank you.
Thanks, everyone. Well, let's move on to Cody Pinks, who has some information to share with us about the data collection that's happening with the hospitals. Cody?
Hi, Tim. I'll let Clint get the slides up real quick for me. Okay, perfect. You can go to the next slide. This is actually gonna be pretty quick. I'm just gonna go over the supply, resupply, and testing supplies tabs in HC Standard. First of all, the most important thing to note is supply questions only need to be updated once a week on Wednesdays. All fields must be completed. Either enter in NA if you don't use supplies, or enter in a 0 if you have none left of that item. Blank values will be counted as missing and will affect compliance. Next slide. The same rules apply for the resupply questions. They only need to be answered once a week as well on Wednesdays. And again, all fields must be filled in. And the last slide is on testing supplies. I don't know if anyone has any specific questions, but recently I received a question from one of the hospitals about if they have these supplies for a machine but cannot use the machine yet, do they count those kits? And I had to take that question up to our HHS data liaison. And the response I received from them was that facilities should not count those kits if they cannot use them, as there is no change to their capacity. So do not count these supplies until you're authorized to use that platform. So just in case that was ever a question anybody else had. And the only other thing I have for today, Tim, is that I wanted to remind everyone that the first enforcement letters are actually coming out tomorrow from CMS. So, but hopefully we're all good there. It seems like got really good compliance happening across the state. So.
Great, thank you, Cody. And obviously, we want to avoid being on those non-compliant lists with CMS because it could have some pretty significant consequences if we're not able to correct those situations. The next area is the medical surge staffing, and I'm just going to have a few words today, but I believe on Friday I'll have a lot more information for you about where we're going with potential surge staffing. Obviously, we're having some significant issues regarding hospital and long-term care staffing issues. We've been hit very, very hard, as the rest of the country, and we've made a number of contacts outside of North Dakota and believe that we're on the verge of being successful in bringing in some additional staffing from outside of the state. And so more about that on Friday. Let me go ahead and move on into the VP3 team and see if either Seth, Roseanne, or Jan have any additional comments from that team.
Thank you, Tim. I don't think we have anything additional to share today. Just always available if anyone has any questions or concerns, and just a phone call away. So thank you.
All right, thanks. Let's go ahead and begin the hospital rounds. Clint, if you'd bring up the information that we're going to attempt to gather once again today. And so please go ahead and complete this information as the slides are coming up so that we can obtain the information in terms of what your current status is for these specific data requests. And let's start once again in the Fargo area, and would really appreciate hearing some specific comments about the status of your hospital, if you're having any significant issues in a particular area, or just have additional conversation or quick pieces of information you want to get from the rest of the hospitals. This would be the forum, the platform to do that in. So any comments or questions from the Fargo area? Hearing none, let's move to the Jamestown area. And nothing in the Jamestown area. How about the Bismarck area? Now over to the Dickinson area. Williston area. The Minot area.
Hi, this is Chris Morrell. I have a question on the Bionex. What's the benefits of the Bionex versus the Abbott rapid testing?
Thanks, Chris. Nicole or anyone else on that team, would you care to respond?
Is Kirby still on, Tim? I think he'd probably be the best.
I'm still on. So, in terms of other rapid testing, are you talking like maybe the Abbott ID Now or any of the other antigen tests? I guess I just need some clarification. So.
Yes.
Okay. Well, I think the one advantage to the Bionex is that it can be performed almost anywhere. You don't need to have a laboratory instrument. All of the antigen testing is pretty rapid in terms of turnaround times. So I think those are the advantages of any exam. There's a possibility of a rapid turnaround, as is the Abbott ID Now. The Abbott ID Now is not antigen, as you know. It is a PCR type of test looking for nucleic acid. I don't see a particular advantage or disadvantage to any of this. I think that from my perspective, in terms of test performance, the important thing is to understand how is that test performing. All of them, I think there's a concern with sensitivity in missing positive tests. And I think even with some of them, there might be some concerns with false positives as well. But I think if you understand what you're testing and you're using the testing for, I think all of them have advantages and all of them have disadvantages. And I'm hard pressed to make a recommendation of one over the other. It just depends on what your needs are and how you need to use the test and what's available for you. So.
Do we know which is more accurate if you're testing symptomatic patients or staff members?
I do not off the top of my head. I think that they're all probably good in that symptomatic situation. But I think having said that, if you're testing a symptomatic individual, especially in North Dakota right now, where we have a high rate of community transmission and the test is negative, you really do want to follow with a positive or follow up with a PCR test because a symptomatic individual should be assumed positive until the PCR is negative. If you get an antigen test that's positive on a symptomatic individual, as Nicole described, that's a reliable result. But if you get a negative on a symptomatic individual, you do want to follow up with the PCR. So.
All right, great questions.
Verify what we're doing is correct.
Great questions. Thanks for the response, Kirby. Anything else from the Minot area? Let's head over to the Devil's Lake area. And finally, the Grand Forks area. All right, we made it around the state. Let's see if we have any final comments before we close out today's information.
Tim, this is Bridget. There are some questions in the chat and some comments in the chat that I think we should address.
Bridget, would you go ahead and read them?
Sure. The first question is, I think many others are for Nicole to maybe confirm what is the sample needed for the test? And I believe that was the Binax now. My understanding is upper nares. Is that correct, Kirby or Nicole?
Yep, so the specimen collection, it's bilateral nares. So it's not a nasal pharyngeal. It goes in about an inch into each nair for 5 seconds, both sides.
Okay. The next question was, please clarify, this is not designed to replace the task force PCR testing.
Correct. The gold standard test will always be the PCR test. This can be either in addition to or can be utilized for surveillance for some of the facilities that aren't testing healthcare workers right now. It's just another added tool for everybody.
Okay. Is there a cost for the test cards and is there a reader?
There's not a cost for the test cards at this time. And then what was the second part of that, Bridget?
Is there a reader for the cards, for the Binax now?
No, this is just the cardboard card.
It's a manual read, I believe, correct?
Yep, it's a manual read. So if you're referring to something like the Abbott ID Now, that's kind of the little, I think we call it a little toaster, like a little box. This is just the card, but it still needs to be placed into a specimen bag for the collection or be read under a hood because it is a live virus. So PPE still needs to be utilized, still needs to be utilized, and it still needs to be a medical provider that's trained in on it to do the test.
Okay. There was a question about where to find the recordings of these meetings, and that is at ndhealth.gov/ET. Click on webcast training, and then COVID-19 is the topic, and that information is right in front of you now. Thank you. The next question was, our attached long-term care received a Binax testing unit. Can this one be used for the CA, or should we request an additional one?
So the Binax now are being directly shipped out by the federal government to the long-term care facilities. I know that some have received them and some are still waiting for theirs. If it's something where they're attached to the critical access hospital, that might be a question for Seth. If the long-term care is receiving that, and then in addition, we can be supplying the hospital.
Yeah, thanks, Nicole. I believe at this point in time, the guidance that I last heard from Unified Command, who had reached out to CMS, was that any reallocation of those devices that had been given to the long-term care facilities needed to be approved. At this point, that request has been made, but I do not believe that we have heard back. And so at this point in time, we do have plenty of the Binax now here ready for distribution. If you're a critical access hospital who's wanting to get these and to start utilizing them, certainly just get in touch with Shar at the number I had shared earlier or her email, and we can get through that process and get them out to you in very short order.
There was a comment in the chat box that the Abbott rapid ID tests have been 99.2% accurate in their studies, so that's great to hear. And then the last question currently that I see is there an updated state surge plan?
So in terms of the surge plan, we did conduct the survey. Unfortunately, we've only had about half of the hospitals respond so far. And so I would implore you, if you've not returned the survey information that was sent out last week, that's asking for your estimates of bed availability for tiers 1, 2A, and 2B. Would you please respond to that survey? It's very important that we collect that information in order to refresh the content of the plan that was put together in April. That's really what we're looking to do, is just refresh the information given the status that we're currently in and see if that causes any significant change in the denominator, or in other words, the full range of what we believe in each of those tiers the maximum bed capacity would be. And that would help us establish where the numerator is at, in other words, what our assessment is on any given day for that specific tier. So nope, not yet, but the delay is because we haven't received a sufficient response yet to this survey. And I know everybody's getting hammered for information requests, and it's difficult to keep track of all of them, but please try and take the time to complete that survey.
Okay, Tim, one more question. Can healthcare working staff self-collect the sample? And that, Nicole?
Yep. So can you say that one more time?
Can the specimen be self-collected by a healthcare worker for the Binax now?
It cannot be self-collected. Just at this point, it has to be used with the way that the emergency use authorization is put in place under the CLIA waive certificate, and has to be performed by a medical professional on everyone that's receiving the test.
All right. Well, I think that was a nice flurry of questions. Thank you for Bridget for stepping in, and thanks to everybody that posed a question as well. I think that's going to wrap it up for us today. Let me see if Tim Blasel has any closing comments.
Tim, I'm looking forward to our discussion probably on Friday. I know you've been putting a lot of work into looking at a couple different, staffing options for the state. So look forward to that discussion on Friday. And I know you and I have spent some time working on that. So, but yeah, no, I'm looking forward to having that discussion with the group on Friday.
Great. Thanks, Tim. Well, thanks to all of the presenters today, and thanks for everyone that participated or has watched today's conversation. And we'll be back again on Friday.